that is better. There is only one thing that is better than finishing a thesis. It is getting awarded for it. I can certify that. So I'm really happy. I'm Dr. ZSOMBOR ZRUBKA from Hungary. Currently, I work at the Health Economic Research Center at Óbuda University. I'm leading that research center. And I also, I'm part of the CORVINUS Institute for Advanced Studies at the CORVINUS University of Budapest. And I finished my my PhD studies at the Doctoral School of Business and Management at CORVINUS University, where my supervisor was Professor Márta Péntek. And just a short information that I'm a kind of PhD student who spent 17 years in the industry in a leadership role, and then I switched to academia, and therefore I was quite fast with my PhD and with my academic career. So the title is A New Method for the Measurement of Acceptable Health States. And what is the background for my research? So probably you hear a lot about the problems of sustainable financing of healthcare. There is a lot of innovation, aging societies, and it is a trouble how to manage the financial budgets. And therefore, in most countries, there is some kind of resource allocation, institution, and decisions are being made about how to allocate healthcare resources for the new technologies. And always the question is what technology to finance or whom to treat. And technically, it's quite easy to answer those questions because we look at the incremental cost effectiveness ratio, we pick two technologies, we measure their costs, we measure their outcomes, and if the cost of a new quality adjusted life year is affordable, then the technology can be financed. So the quality of the decisions, it does not depend on the measurement technology. It depends on, it does not depend on the analytical technology. It depends on the measurement technology. So the better we measure costs and the better we measure the health outcomes, the better decisions we can make. And how do we measure health outcomes currently? This quality adjusted life year, this is the most widespread measure of health gains. And it's a number which somehow unifies the length of life and the quality of life into a single measure. So as you can see on the left side of my chart, if someone lives a full year in full health, that is one quality adjusted life year, and it's in theory, it is equal to living 2 years in a quality of life with 0.5. Now, the problem or the specific characteristic of the QALY is that it is invariant to the severity of disease or other patient characteristics like age. So I show you here that if we have a very, very severe patient, and this severe patient makes a rather great improvement, maybe getting out of a terminal illness and being able to walk, is the same health gain for the society as having maybe 4 individuals only having a mild improvement for a milder disease. The QALYs do not make a difference. And what is the problem with that? That on one hand, these QALYs perfectly fit the normative background of egalitarianism and utilitarianism, and most societies accept those principles for allocating the resources. But the societal preferences about the allocation of health resources are different. Because if we ask people what do they find as a just distribution of health resources, then people will say that they would prefer younger adults over the older ones, and they would prefer to treat more severe patients than the less severe ones if otherwise the conditions are comparable. So the question is that how can we include those societal preferences in a transparent and equitable way into the resource allocation decisions? And there was some work on this topic, on this field. And one concept was acceptable health. And some researchers found that actually people consider some health problems as acceptable as they get older. And some health problems can be regarded as normal part of aging. And therefore, we do not need to provide perfect health always at any age. And another concept, which is a broader philosophical concept or a broader concept of distributional justice, it is sufficientarism. And here the idea is that in resource allocation, the key priority is not that we distribute the goods equally, but we distribute in a way that everybody should have enough. Now, how can we implement it in healthcare? This acceptability of the health states, it is a step towards implementing a sufficientarian kind of distributive system. We have a questionnaire, which is the EQ5D questionnaire, which is the most frequently used questionnaire for the measurement of health for economic evaluation purposes. It's a rather simple questionnaire. And the idea of it is that there are 5 key dimensions of health, like mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. And we think that most of the diseases, no matter if it's a psychiatric disease, an internal condition, or an accident, the consequences of any kind of health problem can be measured along these 5 dimensions. And we can indicate the severity of the problem in 3 levels, like no problems at all in a certain dimension, moderate problems, or severe problems. And by this, we can describe 243 health states, different health states. And this seems to be enough for a strategic level decision-making, a resource allocation decision-making. Now, how do we incorporate this information, which is collected from the patients? How do we incorporate in a decision-making setting? One way is to calculate the QALY. And when we calculate the QALY, then for each 243 different profiles, health profiles, which can be somehow described with this questionnaire, we order a cardinal utility value to any of these health states. And this utility, the value of this utility is 1 if the person is in full health, if there is no health problem in any of the dimensions. Death is denoted with a 0. And also there are some health states, health problems, which have a negative value, which are considered as worse than dead. I do not want to go into the details of how these values are being determined, but there are many well-established methods to somehow connect these health states with these utility values. Now, the idea for acceptability is that we do not render one single value to a health state, but we take the same health state in 6 different ages, and we ask people about whether this health state is acceptable for a certain age. So whether they consider that if life would go on chronically in a given health state, then would it be acceptable from a certain age onwards? And we record the proportion of the general population who consider that from a certain age, that health state would be acceptable. Now, and here is my approach, and here is the novelty that I contributed with my PhD, that so far acceptability was measured along each dimension of health separately. So we had some information about from what age people consider problems with mobility acceptable, and what is the proportion of people, for instance, who consider moderate or severe problems acceptable with mobility. And we had the same information for all the 5 dimensions, but what we did not know, what is the acceptability of problems if they occur together jointly. And we developed a new survey method which was able to measure that. Now, the problem is that if you think that we have 243 health states and 6 ages, then we need to determine the proportion of the population for who consider acceptable 1,458 health states. And this is a lot. So basically, in a normal survey design, it would require tens of thousands of respondents in a very delicate kind of study design to have a proper representative sample. And we created an adaptive algorithm which simplifies this approach and which makes it measurable in normal, usual survey sample. And we use two assumptions. One assumption is that health is monotonous with age, which means that if a health problem is acceptable in a younger age, then we can think that in older ages, that level of health problem is also acceptable. And we have another assumption, which is consistency. And this means that if a problem in a domain is not acceptable, then more severe problems in that domain are not acceptable either. And by this, we can make a lot of deductions about the acceptability of health states. So basically, we did a two-stage survey. In stage one, we used the evaluation by each dimension, and we could determine for a lot of health states that are not acceptable at all based on the evaluation of a single dimension. And then a survey algorithm went on, and for those health states where there were combinations of problems which are potentially acceptable, we went through those problems in a random fashion, and we asked whether jointly they are acceptable. And you can see the concept that based on the answers of the respondents, we could always make deductions about the acceptability of a lot of health states. So the space where we did not know the answer, this became smaller and smaller and smaller. And by that, with 15 questions per respondent, we could get a lot of information from the 1,458 health states. And the result is that we could complete the matrix, and basically we could get a lot of information about all those health states from a small sample, as small sample as 200 respondents from the general population. And you can see that we could draw the curves, the acceptability curves, which on the x-axis you see the utility of these health states. It's a simplification of the 243 health states ordered according to their utility. And on the y-axis, you can see their acceptability. Now, what is the theoretical contribution of that? This is the first time that actually we have a consistent measure that somehow reflects the age and severity related preferences of the population. And we can put this in practice, and we can try to apply sufficientarian theory in decision modeling. And this acceptability information allows us to construct the acceptability adjusted life year. And in this chart, you can see that we have an idea for an acceptable life year, which is basically the time spent in acceptable health. And based on our research, we have the exact function for acceptability. So we can just give a weight of 1 to the time which is spent in an acceptable health, and 0 for those health states which are not acceptable. And by the same token, and with a slightly more difficult or more complex calculations, we can calculate the unacceptable disutilities, the time spent with unacceptable disutilities, which would somehow take the negative of this, and which would calculate how much utility is lost by a death, considering that people think that different severity of health states are acceptable, and what is the lost utility in a certain health state. So if we improve the health of a person, or if we avoid a death, what is the disutility that we can avert?
ZSOMBOR, I'm sorry to interrupt you, but you have 1 minute left.
And this is exactly my last slide. Thank you.
Very good. Sorry for that.
Thank you. So all over, this was my thesis, but I kept on working on that. And we had some further refinements. So we improved the algorithm and did a representative survey in the population on over 1,000 patients or people. We have an advanced statistical model which somehow mitigates the bias that results from this adaptive algorithm. And we are also implementing now these acceptability adjusted life years in a real decision modeling setting. And we are exploring further the association between utilities and acceptability in order to learn more about how people value health. So thank you very much for your patience, and I hope that you will have questions.
Thank you very much, ZSOMBOR, and congratulations.